Welcome to our respiratory interventions lesson. You can find this on page 144 and 145 of your Nurse Workbook 2.0. And the purpose of this video is to give you more information beyond this Nurse Workbook, but to provide you with real-world nursing education as well. In our previous video, we talked about our pneumothorax or pneumothoraxes. And now we're going to get into our chest tubes. So if one of these gets large enough, we're going to have to relieve that pressure inside so we can re-expand that collapsed lung. So if we remember, there is an area that this stuff builds up in, and that's called the pleural membrane. And there's this emergent procedure that we can do if that pressure starts to accumulate and causes that tracheal deviation. So when we see tracheal deviation, a shift to the left or right, we know this pressure is so big that this possibly could impair blood flow so much to our heart that we need to relieve it quickly before a patient goes into cardiac arrest. So we do this thing called a needle chest decompression, and we call this a DART in our medical slang. So let's learn more about our NCDs. So where exactly do we place our needle chest decompressions or our DARTs? So this is a large bore needle that we're gonna insert to the second intercostal space mid-clavicular line to decompress our lung emergently. Okay, so we said a bunch of words there. So this green line is gonna represent our clavicle. So mid-clavicular means that we're gonna draw a line down the center of the clavicle. And the second intercostal space. So our ribs right here, if this is our first rib, and then we have our second rib, and this would be our third rib, this right here is where we're going to dart. And so we're gonna talk mostly about our chest tubes next. And our chest tubes don't go in the same place as our needle chest decompressions. So we want to put a chest tube in the third, fourth, or fifth intercostal space, which is the anterior mid-axillary line. So we have our third rib, our fourth rib, and our fifth rib. And we want to go anterior mid-axillary line. So we have 3 axillary lines in our mid-axillary line. And remember, axillary means armpit. So our first line is this posterior mid-axillary line. And as you can imagine, this is because it's closer to the backside. We have our middle mid-axillary line because it's in the middle of our axillary. And we have our anterior mid-axillary line. So in the case of our chest tube, remember we're gonna come down to our third, fourth, fifth, and we're going to go right at the anterior mid-axillary line. And a chest tube should be treated like a Foley. So we should be avoiding those dependent loops and don't raise the container above the patient. If the tubing becomes clogged or kinked, it can result in a tension pneumothorax. And we never want to clamp the tube for longer than 1 minute. Dressings around the insertion site should always be occlusive. And if the lung re-expands, the chest tube should be removed by the doctor. And to clarify a dependent loop, this means that where the chest tube is attached to the patient all the way to the chest tube container or drainage system should have no loops in this line, because this allows the line to get easily kinked, and then this can build up that pressure back in our chest cavity. Also, it can make the fluid stagnant, and then we can build up an infection in this area. And additionally, we're not going to be getting an accurate drainage of whatever fluid might be in there because it's all being halted by this loop that's in our tubing. So let's start with the anatomy of our chest tube drainage system. So we're going to start with this needleless access port. So this allows for safe needle-free sampling of fluid that's from the drainage system. And this minimizes our risk of any needle stick injuries that can reduce our contamination risk. And next is our inline connector. So this is going to be a secure leak-proof connection between the chest tube and the drainage system. So this maintains the integrity of the system and it prevents air leaks. And we have our multi-position hangers. So these allow us to attach this drainage system in various positions around the patient's bed, so our system's always positioned correctly. Of course, we have our handle that's going to be for easy carrying and for transporting of our patient with this drainage system. And then we have our drainage collection chamber. So this is going to collect fluid drained from the pleural space, and it provides us with an accurate measurement of output and assessment of the fluid's characteristics since it's a clear window. We can also monitor how fast our patient's hemorrhaging from their lung as well, so we can feel confident if they need to go back to surgery or not. So let's look at this blood that's accumulating inside our chamber. So if we look at our first window, this goes up to 200 mLs, and the blood continues collecting, and it goes all the way up here, which looks like this is 650 mLs of blood that has accumulated in our drainage chamber. One of the best things to do is get a marker, and you're going to mark where your initial output was. So you want to put your timestamp of how much has come out. And when you do your assessments, you can go ahead and mark how much the patient is bleeding dependent upon the output you're seeing and the time. And our biggest rule of thumb here is that if we see 300 to 500 milliliters of blood that's happening every hour for multiple hours, then we need to get our trauma team or our surgeon or a doctor and let them know that they're having this much output and they're most likely going to have to go back to surgery. Next, we have our patient tube clamps. So this is going to be used for the temporary clamping of the chest tube during any system changes like getting a new chamber. This could be for troubleshooting, but again, we want to avoid clamping this tube as much as possible because it can create that pressure and make a pneumothorax. And our patient connector is what connects this drainage system to the patient's chest tube that's coming out of their pleural space. We have our swing out floor stand, and this makes it much more sturdy for us to place this chest tube drainage system on the floor so it doesn't easily tip over. And the biggest tip I can give you here is make sure you tape it to the floor if it has to be on the floor. So many people come barreling into a room, they don't even look down, especially if you just put this in, and they will kick it over, and this could potentially rip out of the patient. So get that thick 2-inch tape and tape that thing to the floor as much as you possibly can. And this area is one of the most confusing areas for people to learn when they're first introduced to our chest tube drainage system. So this chamber right here is going to be filled with sterile water. Once we have our patient hooked up and this is a sealed closed system, this little float ball is going to move up and down when our patients are breathing. So this ball is moving with the changes in the patient's pleural pressure. And it also gives us visual feedback of how our drainage system is performing. So this air leak monitor section allows us to detect and monitor the presence of air leaks from the lungs. So if any air leaks are present, then we're gonna see bubbling present in this air leak chamber. In the beginning of our chest tube insertion, our air is being removed from the pleural space. So we might see more bubbling at the start of it. But as we continue to monitor the chest tube drainage system, we should start to see that disappear. So this ball should be moving up and down gradually as we're inhaling and exhaling. And we should start to pick up on a pattern of it too, of how things are going. If we start to see less movement of this ball moving up and down, and we don't see any kind of bubbling at all inside this chamber, this could be a sign of our lung re-expanding. It could also be a sign that there is something wrong. So we always need to troubleshoot first and then go get the doctor and let them know. Our suction monitor bellows is this little accordion right here. So this expands and contracts to indicate our level of suction. And the suction is necessary to help pull out the fluid or air of the pleural space. So the chest tube drainage systems are always set to a -20 pressure of suction. So when the suction monitor bellows reaches this little area right here, this triangle, then we know that we have a -20 suction present. But if the bellow goes below or above this little arrow, then we may have too much or too little suction. And this isn't the suction on the wall, this is going to be our dial. And this dial is right here, known as our dry suction regulator. So this regulator is what controls the amount of suction applied to the system, and this provides that consistent and controlled suction level that's safer for the patient and more convenient. And then we have our water seal chamber. So this acts as a one-way valve that prevents air from re-entering the chest cavity while allowing air and fluid to exit. And this is connected to that air leak monitor that we just talked about. We have our positive pressure release valve, and this is a safety feature that releases excess pressure from the system. So this prevents the risk of that tension pneumothorax that's caused by excessive suction or patient coughing. And our suction port allows for the connection of that suction source to our drainage system so we can apply that -20 pressure to suck the fluid or the air out. And lastly, what is titling? So this is fluid in the water seal chamber that goes up with inspiration and down with expiration, and this is normal. So this is the opposite of mechanically vented patients. When our titling stops, this could mean the lung is re-expanded or a kink is present. This concludes our chest tube lesson. I hope you learned a lot. I will see you in the next one.